and any trigger of infection, any source of infection can again affect the whatever preserved. So when there is a long-standing cirrhosis or long-standing liver disease, the heart gets affected. So the walls of the, because you have put a new liver now, so liver is new. But if during the procedure of the surgery, if the kidneys are getting affected, you have to
Dr. Vaibhav, welcome back. So, doctor, in the previous episode, you spoke about what is a liver transplant, and how lifestyle also can impact us in such a way that we would have to end up needing a liver transplant. Once a patient has been told that now he is going to require a liver transplant, what is the journey he undergoes after that?
Yeah, thank you. Welcome. So once the patient is diagnosed as a chronic liver disease, so he is in regular touch with the hepatologist or the gastroenterologist or the surgeon. So we do the set of labs, a regular routine set of labs as per the institutional protocol, and based on that we start them on medications whatever are needed for um, increased protein intake. It could be in the form of a sachet or a protein biscuit. Then we start them on something called as
So, they are also given protein, extra protein.
yes, we have to give them protein rich diet. And then we put them on an antibiotic for gut flora maintenance, so which is called as a rifa gut. It is nothing but a rifaximin. So it is a basic antibiotic which we start if the patient is not having infection anywhere. Then there are a couple of other medications which are needed to maintain the proper integrity and bile digestion and all those things. These things are taken care by the primary physician or the hepatologist or the gastroenterologist. So once the patient is diagnosed as decompensated liver disease, so he has to undergo when he visits anesthesiologist as say for a transplant, for listing for a transplant. So we assess him overall. All the systems of the body need to be assessed, including like brain, lungs, then liver, heart, kidneys. Then we have to rule out any other issues like whether he is having any deep vein thrombosis. So some patients who are chronic smokers, they can have peripheral arterial diseases, so we have to do a scan. So there are number of tests like MRI, CT scan, then contrast CT to find out how the flow in the liver is. So and then sometimes we have to do a high resolution CT chest, because these patients can have infections in the chest which don't flare up usually because their immunity is suppressed once they are diagnosed as a chronic liver disease. So so when we see the patient, we assess them overall, including all the systems.
Oh, so people who have liver problems would have lower immunity.
Yes, they are having lower immunity and they are more prone for infections. And any trigger of infection, any source of infection can again affect the whatever preserved function of the liver is there. That also can get affected. So they have to be very very careful and avoid going into public places, and avoid any trigger which can have them infection. So so neurologically what we assess is, when as anesthesiologist, what we assess is how is the patient neurologically. So whether he's fully oriented, fully coherent, fully conscious, and had he been facing episodes of encephalopathy in the past. So any patient who has had encephalopathy in the past means that the liver disease has progressed. So how encephalopathy is nothing but like, say suppose I am asking you some direct questions, so you are able to respond it in a proper way. So there are grades of encephalopathy again. So usually what happens is, first grade of encephalopathy, patient sleep cycle is reversed. Okay, so generally as a normal individual person will sleep comfortably in the night for 6 hours or 7 hours. But when a patient of liver disease is there, so he finds difficult to sleep in the night time. So that is sleep reversal cycle. So they tend to sleep more in the morning, or they will complain that I'm having inadequate sleep. So this is the grade 1 encephalopathy. So then as the grade increases, so they will find difficult in concentrating, they will find difficult in speaking, then suddenly they just become mum, or you can say when the grade 4 encephalopathy is there, they are like comatose, they are not even responding to painful stimulus. So these are the grades of encephalopathy. But we have to assess in general how the patient is, how many episodes of encephalopathy he had in the past, because it gives us an idea how to manage the patient and all those things. So then that is a general neurological assessment. Plus they also have peripheral neuropathy. All the patients who have chronic liver disease have peripheral neuropathy, so we have to give them multivitamins, we have to give them thiamine supplementation who are chronic liver disease patients, because alcohol consumption decreases all this multivitamins. So we have to start all these medications and stabilize them. Then coming to the heart, what happens is, because chronic liver disease, it's such a state that there is a severe vasodilatation happening in the body. So there is lot of fluid which is getting accumulated in the body, and when that happens, your heart also gets the flow back. Okay, so the heart is not capable of handling that much of inflow. So there is a term called as cirrhotic cardiomyopathy. So when there is a long term long standing cirrhosis or long standing liver disease, the heart gets affected. So the walls of the heart may not contract regularly, improper contraction may be there, or there may be missed beat. So these conditions we have to rule out before, or there may be areas of ischemia because of NASH or because of smoking, diabetes. Ischemia is nothing but the area of the heart where the blood flow is there. Suddenly, the blood flow decreases. So that area becomes ischemic because there is no flow of the blood happening. So those areas will contract differently. So these changes we can find out with ECG, we can find out with 2D echo. Then we ask them to do a few tests like a 6-minute walk test, where the patient is asked to walk for 6 minutes, and if he is able to do that without getting tired, fatigue, or without having breathlessness, so that means that the patient's reserve is good. So basically this is to check the reserve, how is he going to handle the stress in the intraoperative period. Okay, because when we are sitting here and talking, it's a different thing, even the patient can sit and talk. But when he's subjected to some stress like a surgery, which is a very highly stressful stimulus, so we don't know how his heart is going to react. We may have to use some medications. So at that time, how his heart is going to react, no one knows. So these are the tests which are done to identify what is the reserve, the cardiac reserve. So after this, we come to the pulmonary. So the pulmonary, we have to do basic chest X-ray, we have to do a CT scan, and we have to rule out any interstitial lung disease associated with the liver disease. We do what is called as a pulmonary function test. That is again nothing but to check the reserve. So all the liver patients, all the chronic liver disease patients, they have to get a pulmonary function test, get a fitness from the pulmonologist, and once the pulmonologist clears them for the surgery, we ask them to do exercises, breathing exercises, deep breathing exercises, and then there is something called as incentive spirometry, which is of two types. So one is with the 3 balls. So each ball has volume dedicated to it. So first ball, when they lift, it is 600 ml. Then subsequent balls 300 ml each. So 3 balls 1200 ml. So that means he can easily do 1200 ml. So the reserve is good. Then there is another which is called as Roche, which has a spring effect. So that is also nothing but a spirometer. Then we ask them to do yoga and breath holding. We assess how much time they can hold the breath. After this, coming to liver, now the main problem is liver disease. So whatever the investigations are needed, they are done by the hepatologist and the surgical team. Sometimes we may need extra investigations, like when a patient is having a hepatocellular carcinoma or a PSC. So we have to check the antibody titers. We have to check something which is called as a PIVCA, which gives us, it is a marker for HCC. So yeah, these are the tests which we do for the liver.
Doctor, if a patient has started his journey towards a liver transplant, he or his family, what are the three things they must ask a doctor or they should be aware of, which sometimes they miss? Like many people, the common trends that you see where people don't ask these questions. What should they be aware of?
Yeah, so the thing is, first thing I would like to say is that still people feel that when the patient is having a chronic liver disease, it's not treatable. So that myth is still there among people. So they have to understand that when it is diagnosed at a right time and you have proper follow-ups with the hepatologist, the surgeon, definitely when we catch it at the right time and when you get the liver at the right time, it is very much curable. No? So the family has to come out of this stigma that no, most of the patients who are having liver disease, they don't end up well. So it is from the patient side and from our side, we need to make them understand that you have to be alert when the patient is having a liver disease.
And I want to understand, like, what are the questions they need to ask? They should ask the anesthesiologist, or like, is there something they should be aware of, the family of the patient?
So what happens is once the patient is taken up, like you are talking, I believe, about the when the patient is about to be taken for surgery.
Yeah.
Yeah. Okay. So as an anesthesiologist, when they come us, we explain them what are the risks involved. So like the patient will be in anesthesia for a long duration of time and the patient will be having lines inserted in his neck which directly goes to the heart, and then he may be having drain tubes, he will be having a nasogastric tube. So and patient will be on ventilator for say 10 hours, 12 hours, till the duration of the surgery lasts. So first question what like the patient relatives ask most of the times is how much time will it take for the patient to recover from the anesthesia. So I would like to say that nowadays the anesthetic agents which we are using, they are so they work so nicely that the effect of the anesthetic drugs just weans off very fast. But based on the condition of the patient, we decide whether to electively ventilate the patient on the day of the surgery and take the tube next day from the ventilator, or extubate the patient on the table. So this criteria is called as ERAS, which is a recovery after emergency recovery after surgery, or so uh, it depends on patient to patient. So what we explain them is he may need overnight ventilation and he may need lines inserted for 3 to 4 days more, and then once he gets fully awake, we take them out of the ventilator, and on second day or third day we will start giving something for him to have orally, like trickle water or start some feeds based on his overall condition. Then not all patients will come out very smoothly. So there will be some risk patients where their kidneys are not being functioning very well, their creatinine is high in the preoperative period. So in those patients, we explain them that if in the intraoperative period the urine output is not adequate, or in the postoperative period when the patient ends up having acidosis or lactate, which we do as arterial blood gas analysis regularly for liver patients, they go up, then there is a chance that he may need support to the kidneys, because you have to support the kidneys or otherwise kidneys will shut down, because you have put a new liver now. So liver is new, but if during the procedure of the surgery if the kidneys are getting affected, you have to support the kidneys. So there is something called as a continuous renal replacement therapy, CRRT, which is put for a patients when the patients start having increase in the lactate or acidosis is seen in the body. So this is the special condition which we explain to the patient. Usually the stay in the ICU after a normal liver transplant is done is up 5 to 6 days. So on 5th day or 6th post-operative day, we shift them to the ward and again assess them in the ward for 6 to 7 days. So post-transplant, the stay of the patient is around 14 to 15 days. So you can say 2 weeks the patient is in the hospital. During the first week or first 4 days specifically when the patient is in the ICU, what we do is we do ultrasound Doppler of the liver morning, evening, and we do lab test where we find out how the liver is functioning morning, evening. So this is for first 4 days. After that, we shift to daily once. Once the patient goes in the ward, if needed, we do the tests, the ultrasound Doppler. Otherwise, routine tests we do once in 2 days, and before the patient is getting discharged, again the full set of labs is done, and then the surgeon and the hepatologist decide that patient whether he is fit for discharge or not.
Doctor, what is a better kind of a donor for a liver transplant patient?
Yes, so always it's a good question. So always living donor is always a better to have, because you know the quality of the liver and it's a first degree relative, and they are free of any infections or anything, viral infections or anything, which cannot be very sure about a cadaver. So although we do the tests and everything, but sometimes something can be missed, especially something which is called as a cytomegalovirus, so CMV, so which does impact the graft in the post transplant period. So sometimes it gets missed in the cadaver donation, and living donor is again good because you can time the surgery anytime. Okay, but cadaver is something like you have been put on the waiting list, you have been waiting. So in that period, if something happens to you, your health deteriorates, or liver gets a hit infection, so again you don't know if any active infection is there, you cannot have a transplant, right? So the timing of the surgery is always in our hands when it comes to the living donor.
So the patient requires a surgery. We know that, but how safe is it for a donor? The process of organ donation, especially a partial, part of the liver.
Yeah, so I can tell it from my personal experience that I have worked in a big living donor liver transplant program in Delhi. So in 1.5 years, I never had any complication associated with donors. There will be small issues, like some donors we put epidurals, so they may have some headache or some things. These are acceptable.
Even for delivery that
Yes,
happens.
yes. So even when you go for deliveries or when you do surgeries for spine, that happens. So that's okay. But I have not seen personally any major complication happening for a donor. They can happen, but the incidence is very, very rare. So it is very, very safe for the donors to actually volunteer for living donor.
And how long does it take for a donor to get back to his normal life? Like, when does his liver come back to its normal size?
So basically, whoever is a donor, he's a fit person. Okay, so they don't have usually any comorbidities, and for them recovery as a physical strength or whatever, it's not a problem. Okay, they don't come across any issues, except for we ask them not to lift weight for a period of 2 months, because the surgical area is big, so they can have hernia, incisional hernia, all those things. But otherwise the liver regeneration, it takes 6 to 8 months. So but they can get back to their normal work after 15 days of leave. Only thing which they should take care of is, in the post-operative period, they should not have red meat, because they are left with a little portion of the healthy liver. So red meat is not that easy to digest. So any heavy fat, carbohydrate rich food, they should try to reduce the intake and avoid lifting weights. So that again is notified to them when they get discharged in a paper, what to have and what not to have.
Interesting, doctor. Thank you so much. This was so insightful. I mean, it was so much of it was new to me. Thank you so
Thank
much.
you, thank you, thank you. Pleasure.